came across this document at home on a bookshelf. Since it's written in German, all I could understand was that it was written by my grandfather, Dr. F N Eichel, with two other more famous doctors, Professors Fanconi and Zellweger. I could tell that it was about poliomyelitis and the iron lung, and that it was published in Zurich in 1951. Naturally, I was curious. I'm also fortunate to work with a fellow anaesthetist, Dr. Tamara, who speaks fluent German. And in 2014, I sent the paper back to Switzerland, where Mari was working at the time. And in Basel, she translated the dissertation into English. The title is The Effectiveness of Iron Lung Ventilation in Poliomyelitis. It was striking to see the focus of his work on mechanical ventilation, which is the basis of my trade. Eichel produced the dissertation towards the completion of his medical degree. On the last page of his dissertation, he writes of himself, "I was born in Budapest on the 30th of August 1914 and attended primary and secondary school there, obtaining my matura. Due to the war, I was unable to attend university until 1945, when I enrolled in the medical faculty at Budapest University, completing 7 semesters. In 1949, I left Hungary, continuing and completing my studies at the University of Zurich." I will fill in the gaps and read between the lines to give you a more detailed picture of his life. Eichel was born 1 month after the outbreak of World War I. His father was on the battlefront while he remained with his mother and siblings in Budapest. After completing school, he went on to rabbinical studies in Slovakia. When he returned to Hungary in 1938, he found it impossible to gain a profession due to the numerous clausus quotas. This was a law enacted by the Hungarian government in 1920 to restrict university access and trade opportunities for Jews. So Eichel was making ends meet as a tailor when World War II began. He was then offered the role as the head of the Hungarian branch of the American Joint Distribution Committee, a humanitarian organization. His job was to negotiate on behalf of many Jews with embassies to secure emigration visas, or to get Swiss protection visas for some who remained in Hungary. During this time, Hungary was allied with Germany, who was concentrating its genocidal efforts in the surrounding countries. In 1941, however, Nandor's sister Rose was caught up in one of many mass deportations of Jews. She was among 18,000 Jews who were deported to the Ukraine, where they were massacred. In 1944, when Hungary occupied Germany, the situation for Jews became even more bleak. Nandor, his wife Edith, and 3-year-old son Robert were lucky to be sheltered within the Swiss consulate. Even within the Swiss consulate, on one occasion, they were held at gunpoint but made a narrow escape. Outside, approximately 500,000 Jews were deported to concentration camps or killed there by local squads. This is an image of shoes on the Danube, a memorial to some of those Jews who were shot straight into the Danube. Lucky to have survived the Holocaust, and despite living through dark times, Nandor started to rebuild his life. After medical school in Budapest, they planned to leave as conditions were worsening under communism. Edith, Robert, and their baby Judy moved to Sydney, while he was given a scholarship to Zurich University, where he produced this dissertation. When he arrived in Sydney, he had to repeat 3 years at the University of Sydney Medical School to have his degree recognised. He was the first of 3 generations of Doctors Eichel, his son Robert, also here today, and myself, both being anaesthetists. He practiced as a general practitioner from 1954 until 1998 in his own rooms in Bondi Junction, until he retired at the age of 84 due to poor health. When Eichel arrived in Switzerland in 1949 to complete his medical degree, he began working at the University Children's Hospital in Zurich. These yearly newsletters from the Children's Hospital catalogue all their admissions, which puts polio into context of the other illnesses being treated there at the time. Recurrent polio epidemics of the early 20th century caused an influx of patients. Together with Fanconi and Zellweger, he audited their polio presentations and management. Since respiratory failure was the greatest challenge, their focus was on the effectiveness of the iron lung. Here in Australia, we've been officially polio-free since the year 2000, but the last wild-type polio infection was in 1972. So when and where you were born will determine how familiar you are with the disease. Poliomyelitis, from Greek, literally means grey marrow inflammation, the grey marrow being the cell bodies of the neurons. Poliovirus had been endemic for thousands of years, with infants acquiring immunity by ingestion. In the late 19th century, when sanitation improved, babies' exposure to the virus and thus acquired immunity dropped. This caused the renowned polio epidemics of the 20th century. The dissertation initially describes the pathophysiology of polio. The virus commonly remains in the gastrointestinal tract, with only 2% of cases invading the central nervous system. In the CNS, it lodges in the anterior horn motor nuclei, causing an acute flaccid paralysis with preserved sensation. If it involved the intercostal muscles and the diaphragm, respiratory failure occurred. In half of the CNS cases, paralysis was permanent, and the distribution determined the extent of the morbidity. Around 80% of paralytic cases involved only the spinal cord, and 20% ascended to the bulbar cranial nerves. The dissertation also mentions respiratory and circulatory centre involvement, which in their experience were the most ominous. From 1946 to 1949, they had 383 children admitted with acute polio. Out of those, 23 children had respiratory failure. Since the iron lung was received at the end of 1946, the first 4 children weren't able to be treated, leaving the 19 cases described in his dissertation. The iron lung is a colloquial term that was coined for the drinker negative pressure tank ventilator in 1929. Tank ventilators had already been around for almost 100 years, originating in Scotland in 1838. Dr. Drinker and colleagues from Boston had been commissioned in the 1920s to design a ventilator for the purpose of resuscitation of industrial casualties. However, the iron lung was then used internationally in both acute and chronic paralytic polio. The Children's Hospital Zurich newsletter of 1946 reports the news of being given an iron lung by the American Army in Germany. The hospital then purchased a further 2 that same year. The device wasn't specified in the newsletter, but being from America, it may have been a drinker apparatus or the Emerson tank ventilator commonly used in the US, which was quieter, lighter, more efficient, and half the price. The iron lung was a welcome addition to the Children's Hospital, as it was more effective than the other equipment being used there at the time. The biomotor from Hungary is the first alternative tool described in the dissertation. It was an airtight, rigid dome extending from the upper sternum to pubis. With foot-operated bellows, pressure transmitted to the abdomen moved the diaphragm, which would cause some tidal respiration. This had a corresponding effect on venous return to the heart. Eichel comments that the biomotor was only effective in very mild cases of diaphragm paralysis. When it was used for more severe cases of respiratory paralysis, they noted extensive atelectasis in the upper and medial lung. He quotes other investigators with similar experience with the biomotor, with also having poor efficacy. The next device he describes was the whip apparatus, known as the rocking bed in the USA. It was designed to produce passive diaphragmatic movement and passive ventilation. Seesawing the patient for a few hours at a time could generate some ventilation. It was used only occasionally in their hospital and was only effective, again, for very mild cases of diaphragmatic paralysis, not the severe cases of polio that they were treating. Phrenic nerve stimulation was initially described by Duchenne in 1872. Eichel quotes the later work published by Sarnoff at Harvard in 1948. Both phrenic nerves were stimulated by an electric current causing rhythmic diaphragmatic contraction. They demonstrated a very modest increase in oxygen saturations from 97 to 98% on room air. Eichel refers to this technique as much discussed if little used in practice. He reports on having tried it on several patients with respiratory paralysis and found it to be ineffective. So given these alternatives for respiratory support, Eichel concludes that until now the most important mechanism of artificial ventilation has been with the iron lung. He elaborates on its advantages and limitations. Patients were commonly ventilated at -10 to 15 to +2 to 5 millimeters of mercury. Their head and face were free, which was the main advantage over the positive pressure devices available at the time, which needed either a face mask, head box, or an instrumented airway. Side openings to the airtight tank gave access to patients for nursing care, and there was a manual pump to provide backup if electricity was lost. However, there was poor access for physiotherapy, which often resulted in limb wasting and contractures, and higher respiratory rates couldn't be achieved for babies. There was some debate about when to initiate or stop treatment. The onset of respiratory failure was highly variable between patients. Mostly they used clinical signs to initiate treatment, but they did mention using a Millikan and Smalls oximeter, which had been invented in the US in 1940. They had several considerations on when to remove the child from the iron lung. They were concerned about muscle atrophy with passive ventilation and psychological dependence. However, they were also aware of hypoxic brain injury if patients were removed prematurely. And unfortunately, this had occurred in one of their patients who was forced to be removed from the ventilator to accommodate a seemingly more needy patient at the time. To determine the effectiveness of the iron lung as a treatment for paralytic polio, Eichel analysed the 19 cases and their outcomes. In all cases, the initial viral presentation was similar, but the outcomes were largely influenced by the extent of the CNS infection. One of their cases illustrates the disease process and the limitations of the iron lung. A 7-year-old girl was admitted in late spring of 1948. She had a 2-day history of fever, vomiting, and sore throat. On day 5, she had leg pain, progressing to leg and trunk weakness. A lumbar puncture showed raised white cells and a positive gold sol test, meaning elevated protein levels. By day 7, she was drowsy with a respiratory rate of 42, so she was placed in the iron lung at 3 a.m. On day 8, she was unconscious and diaphoretic within the iron lung. She was profoundly cyanotic, using her accessory muscles and making gasping, irregular breaths. She was drooling, which indicated impaired swallowing. She died at 9 p.m. of respiratory failure. At autopsy, she had spinal, medullary, and pons poliomyelitis. She had aspiration pneumonitis, pulmonary edema, and a dilated right heart. This case shows the severest end of the spectrum, which prompted Eichel, Zellweger, and Fanconi to consider how they could try to overcome the limitations of the iron lung. In the Zurich series, the survival rates were highest when the iron lung was used for spinal weakness. But once bulbar, circulatory, or respiratory centres were involved, the outcomes were very poor. The overall mortality rate for the 19 respiratory failure cases on the iron lung was 47%. Of the surviving 10, 5 made a complete recovery and 5 had a permanent disability. It was clear that the iron lung had limitations, one of which was synchronization of the patient. Eichel mentions the use of IM curare in cases with respiratory centre involvement, but it seems they didn't use this technique in Zurich. Curare for polio had first been described in 1945 by an orthopedic surgeon named Ranzerhoff in New Jersey. His aim was to weaken the patients to reduce muscle spasm and contractures and aid physiotherapy. There is no mention of the effects on respiration, an early example of the different priorities of surgeons, especially orthopods, I hope there are none here today, and anaesthetists. With more of a focus on respiratory care, a year later, Bauer in California used IM curare to offset the irregular respiration from the damaged respiratory centre and reduce laryngospasm. Another limitation of the iron lungs' effectiveness was airway soiling and obstruction. Eichel noted that bulbar palsy caused aspiration pneumonia, atelectasis, and pulmonary edema, and compounded the respiratory paralysis. He quotes Galloway, published in the Journal of the AMA in 1943, who recommended tracheotomy for intractable respiratory failure in polio. Eichel concludes that in cases of bulbar palsy, tracheostomy and prophylactic penicillin injections should be used to avoid lung complications. In 1948 in Los Angeles, Bauer and Bennett began using positive pressure to treat polio. They used the Bennett flow-sensitive pressure breathing unit to supplement tank ventilation via tracheostomy, tracheal tube or mask. They reported a drop in mortality from around 70% to 17%. Similar conclusions were drawn from the Copenhagen polio experience of 1952. Professor Larson called for help from his anaesthetic colleague, Dr. Bjorn Ibsen, when 27 out of his 31 patients with bulbar polio had died in the iron lung. Ibsen inserted a tracheostomy and hand-bag ventilated a 12-year-old girl in extremis. She was then placed in the iron lung, but still required manual positive pressure ventilation to normalise the CO2 which they were measuring. Encouraged by the success of this new strategy, they adopted it as a protocol for managing respiratory failure with upper airway paralysis. Their regimen consisted of early oral intubation or tracheostomy, manual positive pressure ventilation, and treatment of shock with serum, blood, and vasopressors. During the 1952 epidemic, 300 patients were managed with these techniques, and their mortality rates fell from 87% to 22%. As the same conclusions were being drawn around the world from their experiences with the iron lung in polio, the 1950s became the turning point from negative to positive pressure ventilation and the origin of the modern intensive care paradigm. It's hard to believe that 60 years ago this disease was taking scores of lives, and it's completely unknown to the current generation in Australia. After the introduction of Salk's injectable vaccine in 1956, the incidence of polio in the US was reduced by more than 90%. Sabin's oral polio vaccine replaced the Salk vaccine in 1962. In 1988, the Global Polio Eradication Initiative was launched as a public-private partnership with governments, the WHO and others, achieving a 99% drop in polio cases. The oral polio vaccine, which provides superior gut immunity, was widely administered, but unfortunately several cases of vaccine-associated paralytic polio developed. Currently in Australia, only the injection is on the immunisation schedule, as it can't cause paralytic polio. Wild-type polio remains endemic only in Pakistan, Afghanistan and Nigeria, where conflict and healthcare challenges have prevented progress. Whilst herd immunity due to immunisation remains high, the risk of polio infection is low. However, even within Australia, where some parents opt out of immunisation for their children, they become vulnerable to polio. The dark red on this map shows high rates of objectors that are currently dropping levels below effective herd immunity. And on a personal note, I'd like to thank Mari Drew, who couldn't be here today, but for providing me with the translation, which opened up the work to further research, and Michael Cooper for all your time and help getting the research to light. Thank you.
Tamara, well, I don't know if anyone else knows, when a patient was on an iron lung, because the negative pressure, their air is being sucked in and out through their larynx and trachea. How easy was it to talk if you were being ventilated by an iron lung. Has anybody ever seen a patient actually?
I think they stopped it for a few seconds to allow, and they also had writing to communicate. I've seen patients on iron lungs, and I believe that was one of the procedures.
So you would talk between the breaths?
But I'm very vague about it. But certainly they had a mirror and they had a slate.
I remember being a registrar at Prince Henry with Tom Torner. Would have been probably a resident in the mid-80s. And he had a few of his patients that would come from the country who were iron lung dependent to see him. And they would, have conversations. And he would, sometimes they needed central lines. And his famous patient, I think called Barbara Milgate, as I recall, she was the first polio person to have a baby. I think in an iron lung. Knows her name? Yeah, Barbara Milgate was the name, and she came to Prince Henry in the registrars quite often for respiratory care in iron lung. So yeah, they could talk and they could have babies.
Could I ask a question, please? You mentioned Björn Ibsen and an American who both worked with positive pressure.
Yep.
I have the impression that Björn Ibsen is still very famous worldwide. What about the American? Why isn't he that famous?
I think that's an excellent question, and that's why I did include the dates. So really the first people who were talking about tracheostomy were in 1943, and then the Americans did precede his work. So it's a matter of, publication and marketing that someone's taken up the story of the Copenhagen epidemic as the turning point, when really 4 or 5 years earlier they were already doing it in the United States.
I'll make just one personal note. We had very bad polio epidemic in Malta just after the Americans made contact with us during the war, and the children with polio were treated in an old palace of the Grand Master of the Knights, and medical students were recruited to help with the nursing, 2 of them being my cousins, one of whom died only 4 days ago. And I was telling my children that Hilda, my cousin, was involved in the nursing of polio children.
I was just wondering if Ibsen was famous because he recruited all the medical students to hand ventilate positively because they didn't have space or the number of iron lungs, and they were on 8-hour shifts, 24/7.
So the Americans were using a machine and the Danish were using manpower.
Yeah.
Are you talking about the Americans or the Danes?
No, the Danes.
Yeah. Yeah.
That orthopaedic surgeon you mentioned, was he American?
Yes.
He was.
I mean, his name is Ranzerhoff, so I don't know where he was born, but certainly he was from New Jersey.
Because curare was only introduced into medicine in 1942, late 1942, and it never took off in the US for anything, because in anaesthesia for a long time, because they only had nurse anaesthetists basically, and they didn't know how to use it, like they couldn't use chloroform and a lot of other things. But I just wondered, because curare was a sort of verboten in the US.
I mean,
So he must have been somewhere else.
He came up with his own doses. He had a dosing range and regimen that they were using. So it's quite amazing that an orthopaedic surgeon was using a muscle relaxant.
Sure.
Just if anybody's interested, I mentioned Tamara earlier, there's a great book published in 2005 called The Polio Story in the US by a guy called David Oshitsky. And it's one of the 2 medical history books to win the Pulitzer Prize for history. I've seen a bit of it. It's a fantastic book. So for anybody who's interested.
I just add one other thing. I mean, having a baby in the iron lung is one thing, but she must have conceived before she got polio, I would have thought.
Not necessarily, because they used to have some time out of the lung,
yeah.
depending
Oh,
on
yeah.
how badly affected they were.
Oh, that's right. No, well, I mean, you couldn't conceive in a lower lung.
No, no. It was
Until recently, I just seen the single-person ventilators. A few months ago, I saw a photograph which showed a wall-like structure with the heads of children sticking out of it. It's like a huge wall with about 3 or 4 children's heads sticking out, and nurses attending to them. And it's the first time I'd seen that kind of photograph of a multi-person unit of polio. So on this day, a long time ago, about 10:30 in the morning, it was when Morton had finished his anaesthetic, and Dr. Warren reportedly said, "This is no humbug." But later on the day, or the entry for that day in his journal says that today did an interesting case. So I hope we've had an interesting day today to celebrate World Anaesthesia Day. I want to thank our overseas visitors, Dr. John Paul, and Dr. Westop, who came from across the wide stretch of water between New South Wales and Victoria, who came at their own expense because unfortunately our registration fee only paid for the air we breathed today. We've had a wonderful morning, and I hope you look forward to future meetings of this type in Sydney, and I hope you'll attend in future as well. I want to thank